The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is I Had Brain Surgery, What's Next? My name is Umbrain Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker today. Dr. Linda M. Liau is Chair of the Department of Neurosurgery at the David Geffen School of Medicine at UCLA and Director of the UCLA Brain Tumor Center. She is internationally recognized for her achievements in understanding the neuroimmunology of malignant brain tumors and pioneering the use of dendritic cell-based vaccines for glioblastoma. Clinically, she has developed novel ways to map brain function during awake brain tumor surgeries and specializes in fMRI-guided surgery for brain tumors in eloquent areas. Dr. Liau has received numerous awards for her research and academic accomplishments. She was elected to the Society of Neurological Surgeons in 2013 and to the National Academy of Medicine in 2018. Thank you so much for joining us, Dr. Liau. You may now begin your presentation.
Well, thank you so much for having me. Let me see if I can get my video on. Great, and thank you. I'm going to start with my disclosures and then move on to learning objectives. So today, my talk today is going to focus on these 4 objectives. One is to learn about surgical strategies implemented in order to improve outcomes and the postoperative experience for brain tumor patients. Secondly, we're going to provide an overview of the postoperative patient experience and rehabilitation process. Learn about short-term and long-term side effects associated with surgery and how these are managed, and understand what treatments may be administered post-surgery as part of your treatment plan and how these decisions are made. So in order to get the best outcomes from your surgery, I think it is important to prepare for brain tumor surgery. So now there's a growing I guess, field of prehab for surgery, and it'd be just as important as the rehab after surgery. So important things to consider is to make an appointment with your primary care doctor to get a preoperative history, physical exam, and preoperative lab tests within 30 days of surgery. And if you happen to have other medical problems or are under the care of a specialist, such as a cardiologist, a pulmonologist, hematologist, do ask the surgeon for further pre-op evaluation if necessary, because it's good to plan for any of these possible situations that could occur from surgery if you do have underlying comorbidities. And then on a personal and social level, it's always good to have an advanced healthcare directive, and it's good to designate one family member or friend to serve as the primary contact person to convey information to. So in terms of preoperative medication management, things to think about are really important things to think about related to surgery lie in these kind of 4 categories. One is to avoid blood thinning medications at least 7 to 14 days before and after surgery. So if you are taking drugs like aspirins, Plavix, Coumadin, Pradaxa, Xarelto, Eliquis, it's important that you stop these medications before surgery because they could increase the risk of bleeding. And then, of course, have good management of diabetes medications, high blood pressure medications, and seizure medications, because the better controlled these conditions are before surgery, the better the outcomes would be after surgery. So what are some surgical strategies to improve outcomes? I'll start with that as the first point of discussion. So if you are diagnosed with a brain tumor, usually it's done by MRI scan, and you see an MRI scan that's suggestive of a high-grade brain tumor or any type of brain tumor for that matter. The goal of surgery is really maximal safe resection. Or when maximal safe resection is not feasible, there are the options for stereotactic biopsy, open biopsy, or subtotal resection, depending on what areas of the tumor can be safely resected. So ultimately, the goals of surgery for brain tumors are really to optimize the risk-benefit ratio for patients. It's basically to maximize the amount of tumor tissue removed, and then minimize the risk of functional neurologic deficit. So it's not enough to just take out as much tumor as possible if that's going to cause permanent neurologic deficit. So these are kind of risk-benefit calculations and analyses that we as surgeons do for every case going into surgery and planning for the surgery. And the reason to maximize the amount of tumor tissue removed, as opposed to, for instance, just doing a needle biopsy, in some instances, is that the larger the piece of tissue we have, the less the risk of misdiagnosis due to sampling error. And nowadays, there is the requirement for larger amounts of tissue, sometimes for the molecular diagnostics and next generation sequencing that's done on many of these tumors. And then of course, if you have a very large tumor, taking it out is good to reduce the mass effect and swelling. And then the concept of cytoreduction just simply means that if we reduce the size of the tumor, even though we may not necessarily get every single tumor cell out, whatever is left behind, the smaller that is, hopefully the chances of subsequent treatment working is greater. So as far as optimizing that risk-benefit ratio for surgical resections, we use a lot of imaging to guide our tumor resections these days. And really the two important things to see are the tumor. We want to know where the tumor is, and also the brain, what areas of the brain are functional or what we call eloquent and cannot be safely taken out. So again, the goal is to take out as much of the tumor, but spare as much of the normal functional brain. And there's different ways to image tumor based on metabolic imaging, such as MR spectroscopy, MR perfusion studies, and PET imaging. And then to image the functional areas of the brain, we typically use modalities like functional MRI scans, which looks at the cortex or the gray matter of the brain that's functional, and then diffuser tensor imaging tractography, or what people call DTI tractography, to look at the white matter. So here's an example of how, some practical examples of how we use this technology to guide surgical resections for better outcomes. So for instance, if you have a very diffuse tumor, you can see this is a very diffuse tumor. It occupies a large segment of the left frontal lobe, which is eloquent in the sense that, motor areas are here. And then there are language areas in this vicinity. How do you decide where to get the most diagnostic biopsy? And I've run into this situation where patients get biopsies at outside places, and unfortunately they are not diagnostic because of the location where the tumor was taken. And it's difficult to really tell just based on MRI scan where the most diagnostic areas are. So some modalities that can be used to improve diagnostic accuracy are things like MR spectroscopy. So for instance, in this particular case, this is a multi-voxel MR spectroscopy scan. And you could look at each little square here, each little voxel, and look at this is really the chemical composition of that particular square on the MRI scan. So what an MR spectroscopy looks for is the ratio of choline, which is this peak here, versus creatinine. And the higher the ratio, the more likely that this is to be a grade tumor or more diagnostic area to biopsy. So if you overlay that on the MRI scan, you actually see there are some discrete areas here that have very high choline to creatine ratios. And this would be the optimal place to get the most diagnostic biopsy. Because what we don't want is to miss a diagnosis because we biopsied or resected or analyzed the wrong area of tumor. Some more advanced MRI imaging techniques that have been developed over the recent years can also guide where and how much tumor we take out. This was a study done by Ben Ellingson with our team here at UCLA, and what it shows is kind of the advantages of advanced MRI imaging modalities such as cerebral blood volume, and then also we're using pH-weighted MR scans. And this is an example of, for instance, a regular MRI scan with contrast. And then you could see the flare often shows areas of non-enhancing either tumor or swelling. You know, it's sometimes very difficult to tell whether this non-enhancing area is edema, swelling, or actual tumor. So that's where we rely on higher level MRI technologies to really kind of differentiate the two. So for instance, cerebral blood volume, in this case, you see there is increased cerebral blood volume here in some areas of the contrast enhancement, but where it's not enhancing, we actually do not see increased cerebral blood volume, and we don't see that on the pH scan either. So it turned out that this area was tumor, this area was necrotic tumor, and then this area here was actually swelling or edema. Conversely, we also see the opposite, where we see non-enhancing tumor that sometimes we don't pick up on one of these two modalities, but then we do pick up on, you know, for instance, this one, we don't see it on cerebral blood volume, but we see it on pH imaging. So the most diagnostic area would be where we kind of see overlap of the two. So this is how we utilize these different imaging modalities. And these are all just MRI scans. So for the patient, it's just an MRI scan. These are all post-processing things that we do on our end to really determine what's tumor and what's not. Another imaging modality that's commonly used to determine where the tumor is PET scanning. So unlike MRI, PET scan is really a metabolic scan. So if MRI looks at structure, and you can actually see the MRI, it has a pretty good resolution in terms of the structures of the brain. The PET scan resolution is not as good in terms of structural anatomy, but what it does show us are these hot spots, you know, these areas that take up increased PET tracers, and it helps to differentiate, for instance, things like treatment effect versus rate versus actual tumor, or even stroke versus a low-grade tumor. But it is important to get the right type of PET scan. So the traditional PET scans are glucose PETs. And this is the standard PET scans, and they're good. They're good for what we call extracranial tumors, such as metastatic tumors or meningiomas or really very highly malignant tumors, but not as good for for tumors within the brain, because the brain itself, the cerebral cortex, actually takes up a lot of glucose. So you get a lot of background from that when we're talking about brain tumors. And for tumors for the rest of the body, glucose PET is actually very useful. So sometimes we use amino acid PET scans, and these tend to be more sensitive for primary brain tumors, particularly lower grade tumors. And there are different types of tracers that are used, and these are all kind of similar in utilization, in the sense that there are amino acid PET scans that are used to detect lower grade tumors. So things such as MET PET, FET PET, and DOPA PET, which are all different types of amino acids. And this is just an example of how we utilize, amino acid PET scans to help differentiate, for instance, what's a recurrent glioblastoma. So in this case, there was a contrast enhancing lesion here that was actually negative on the glucose PET, because there was a lot of background from the gray matter of the brain. But on the dopamine or amino acid PET, we actually see that it is a hot spot, and that kind of helps us determine whether or not this patient should undergo surgery for this. Similarly, this is a low-grade tumor, and these amino acid PET scans tend to be more sensitive for low-grade tumors than the glucose PET scans are. So those were just different imaging modalities that help us image the brain tumor. Now, as I mentioned, the other thing that's important to spare is the functional brain areas. And there's two main areas of the brain that we like to spare, which is the gray matter and the white matter, the cortex and the fiber tracts connecting the cortex. So what a functional MRI scan is it's again for the patient, just an MRI scan. But during the scan, patients are often asked to talk, to name objects, to move their hands and toes, and areas of the brain that serve those functions actually light up on the on the functional MRI scan. Just kind of, you know, in a simplistic way to describe this is that those areas of the brain take up increased blood flow, and the MRI scan is able to detect that. So this is just an example of a patient undergoing a functional MRI scan. We actually, this particular patient, he was a musician, so we're actually mapping out music function. So, and more specifically, music comprehension function. But this kind of shows how a functional MRI scan can be used to detect areas of the brain that have eloquent functions and areas that we want to avoid during surgery or preserve during surgery.
Areas in his brain.
You did an excellent job of staying nice and still and relaxed, so keep up the good work.
The MRI team maps Dominic's speech and language areas as he looks at pictures and responds to automated questions.
Jewelry for your finger. Eagle's fire. Color of snow.
There's no room for a musical instrument in the MRI, but now Dominic silently creates music in his brain. They're hunting for the source of melody. No medical team has ever tried this before.
It would be great if you could sort of spontaneously generate a melody. Yeah, that would be ideal. Okay, all right, here we go.
A lot is riding on the results. The proximity of Dominic's melody generation to his tumor, along with his motor and speech functions, will determine just how difficult his brain surgery will be, or if it can be done at all. Dominic's fMRI revealed a cancerous tumor surrounded by several critical areas, regions that govern his motor movements, his speech, his ability to make music, and the fiber tracts which convey that information. Moves quickly to the part of the tumor near where Dominic's brain creates music. It's time for him to sing. As long as Dominic sings, Dr. Liau knows she's on safe ground.
That's really good. Wow.
His singing helps Dr. Liau finish removing the tumor quickly and with a minimal loss of blood. Now Dominic is ready for a well-earned nap.
So that's just an example of how we utilize functional MRI to plan the surgery preoperatively, and then to use that information to guide our awake surgeries intraoperatively. And we do awake surgeries when tumors are in what we call eloquent areas. And eloquent areas could be areas that subserve language, areas that subserve music function, if that's something that the patients want to preserve, or motor functions. And this is just an example of an fMRI and a surgical case that we did many years ago now that shows that, for instance, language can be in different parts of the brain. In this particular patient, she was bilingual, and A was English and B was Spanish. So depending on the function that you're trying to preserve, these adjuvant scans really do help us guide safer surgeries for optimal outcomes. So that's functional MRI helps us map the gray matter, the cortex. But what we also need to know are the fiber tracts that can connect the neurons to each other so that they communicate. Because there are areas of the brain that function to control expressive language, the ability to speak, and then areas of the brain, for instance, that control the ability to understand language. And of course, the two need to connect in order for for a functional outcome. So that's where DTI tractography comes in, and this is actually now pretty standard in most neuronavigational systems, where we could actually map the fiber tracts leading from the cortex, kind of, for instance, let's say the language areas or the motor areas, and then the fiber tracts that go down to the motor fibers down to the spinal cord, down to your arms and legs. And then this is kind of how, a three-dimensional model of how the tumor sits within all of that. And nowadays for every individual patient, we can make this three-dimensional model of the tumor, all the functional areas and all the fibers connecting all of these areas. And the goal of surgery is really to take out the tumor without damaging all the important structures around it. And that's having that ability to visualize that ahead of time, ahead of surgery, does help make for a safer surgical resection and also prevent any unexpected outcomes during the surgery or afterwards. And all that can be fused into a neuronavigational device that is now very commonly used in the operating room for these surgical procedures. And what this device is essentially like a GPS for the brain. We have a pointer that we could point to any area of the brain while the patient is undergoing brain surgery, and that area is lights up, or actually is indicated on a screen in the operating room, so we know exactly where we are. So this has really helped in terms of the precision of surgical resections for tumors. So there are some areas of tumors that require different types of approaches. And I often get asked, well, can I have a tumor taken out, for instance, through the nose, or where the incision is after you're going to be in order to take out the tumor. And where the incision is and the approach to the tumor all has to do with the location and the type of tumor. So it has to do with the type, the size, and the location of the tumor. Those are kind of the three things that dictate the approach to surgery. And this is one approach. It's actually going through the nose with an endoscope. And this is appropriate for tumors kind of in this area, the area, right into what we call the sphenoid sinus. The most common type of tumor being taken out through the nose are pituitary adenomas, but there are these other types that could also be resected. And then this is a view of what we see in the operating room. The resolution now is quite good in terms of what we can see through the endoscope. And this is a case done by my colleague, Dr. Bergsnyder, looking through the endoscope, looking to take out a tumor, through the nose. What about inoperable brain tumors? So there are some tumors that, despite all our imaging technologies and our surgical approaches, it's just not in a safe area of the brain to resect. So for inoperable brain tumors, there is the option of MR guided biopsy and laser ablation. So this is a technique where you could actually thermally ablate the tumor, but it doesn't actually take the tumor out. So it's not, the kind of ideal situation. If you have a tumor that can be resected, the preferred treatment still is, optimal, safe, maximal resection. But if the tumor is, for instance, deep in the brainstem or can't be resected safely, then this is another option whereby we can drill a burr hole and put a laser guided probe into the tumor and essentially ablate it that way. And here's an example of how this works. The probe can be inserted into the brain tumor, and then under MRI guidance, we actually can see the thermal ablation. This is an example of laser interstitial thermal therapy, or LIT. Some of you may have heard that acronym. And this is essentially what it is. It's a thermal ablation of tumors in the brain. And this can be used for deep tumors or tumors in an area that is critical and that can't be taken out surgically. Another type of technology that's in development is the use of MR-guided focused ultrasound. This is already FDA approved for movement disorders, for essential tremor and other types of movement disorders, but not yet for brain tumors. But it is an area that many of us are exploring in terms of research possibilities that can allow for instance, opening of the blood-brain barrier via ultrasound, so that therapeutics can better penetrate into the brain. So after surgery, obviously the next question is what's next. So I just want to spend the rest of this time talking about the post-op patient experience, the rehabilitation, and then what kind of questions and what kind of options there are after brain tumor surgery. So obviously we want to optimize the post-op experience as much as possible. We want to have happy, smiling patients. This is a patient of mine, and luckily she was smiling after surgery. The scar or the incision of that patients have after surgery really depends on the location of the tumor. So for instance, if you had your tumor resected through the nose, there would be no incision. The incision would be inside the nose. If you had a temporal lobe tumor, the incision would be closer to the temporal lobe. If you had a tumor near the frontal lobe, the incision would be closer to that. And this is an incision of a patient with a tumor near the back of the head, the cerebellum. And the goal is really to keep the incision. We try to keep the incision behind the hairline, so that once the hair grows back, you actually don't see the scar. So during the hospitalization, most patients will immediately go to the post-anesthesia care unit, or the PACU. And most hospitals have this unit where patients recover from anesthesia. And then typically patients would go to the neuro ICU or a step-down unit for a day. And then to the hospital neurosurgery nursing unit, or what we call floor. Patients usually, if all goes well, the stay is usually 2 or 3 days in the hospital. But the length of hospital stay and the rehabilitation afterwards really depends on as I mentioned, the location, the size of the tumor, and the extent of the surgery, and the approach that's used during the surgery. And the extent of the surgery, sometimes it's only a biopsy, because we can't take out the tumor totally, or it's a subtotal resection, or what we call a gross total resection. After surgery, patients may find that they have these devices that are used. So the Foley catheter is a catheter, that is inserted into the bladder, and that helps with preventing bladder retention, because with the anesthesia, it is things like bowel and bladder functions do slow down, so the catheters are used to help with that. A risk of surgery, of brain tumor surgery, is often deep vein thromboses or blood clots in the legs. So we use these compression stockings to prevent blood clots. Another risk following long surgeries is what we call atelectasis, which is collapse of the lungs. And in order to prevent that after surgery, patients are usually encouraged to use this device called an incentive spirometer. And that's really to help inflate the lungs after surgery so that we don't get collapse. And then early mobilization has been found to enhance recovery. So that the quicker we can get patients up and mobilized, hopefully the better the long-term recovery. And rehabilitation therapy after surgery usually involves one of these 3 things, or all of these 3 things. You have physical therapy, occupational therapy, or speech language pathology. And oftentimes with patients who have tumors in eloquent areas, such as motor or language areas, patients do require therapy afterwards to get back to where they were before, or to recover the function that they lost because of the tumor. So physical therapy is used to assess the ability to walk safely and climb stairs before leaving the hospital. We have patients, we always assess our patients for that. Occupational therapy is really dealing with the activities of daily living. And then speech therapy gets involved when, for instance, if a tumor is near language areas and patients need help with regaining language functions. And then just some tips about going home. It's good to have a good support system at home. As I mentioned, we evaluate the functional abilities, and then some things to keep in mind. Try not to have to drive or work until cleared by your surgeon, and then schedule your post-op follow-up visits, usually within 2 to 3 weeks, so you can get your staples and sutures removed. So as far as the recovery process, as I mentioned, the time required to recover after brain surgery is different and for each patient. And it really depends on the tumor type, the size, and the location, the procedures used to remove the tumor, the patient's age and overall health, and the patient's functional status prior to surgery. And you may have heard of something called the Karnofsky Performance Score. So we often use this kind of functional status to assess whether a patient's a good candidate for surgery and whether the recovery after surgery it can be improved. So for instance, the Karnofsky Performance Score is graded on a scale of 0 to 100. 100 is essentially a patient with no symptoms at all and just happened to get an MRI scan for some other reason and was found to have a brain tumor. So that's a person with what we call a KPS of 100. And then the scale goes down to mild symptoms, moderate symptoms, patients who need assistance or occasional or considerable assistance. Usually for surgery, the best outcomes are in patients with a KPS of 70 or above. When we get down to this level where patients are bedridden for more than half of the day, even with surgery, the functional rehab and recovery oftentimes is not able to get patients back to an independent level of living. So sometimes decisions are made as to whether or not surgery is appropriate based not just on the tumor characteristics, but also on the patient, either functional status or overall health. And then again, everyone's recovery process is different. Recovery may take a few weeks to a few months. So a lot of times patients don't feel back to normal for at least 6 weeks. And it's usually average time of recovery is about 6 weeks to 3 months. And then for some patients, depending on the location of the tumor, even if the surgery goes very well, recovery just involves learning to adjust to permanent changes or a new normal, just because the brain, especially for very large tumors near functional areas, the brain is affected and needs to shift to a new normal. Part of the recovery process also involves swelling of the brain. As I pointed out, a lot of times patients get edema after brain surgery, and that is normal. Symptoms may temporarily worsen before they get better. And typically, the first 72 hours are the kind of the time points where you have the most swelling after surgery. So a lot of patients do have worsening symptoms in that first 24 to 72 hours. But they do resolve. So that's something to keep in mind. Don't be too concerned as long as the MRI scan looks good and your physician is feeling good about the recovery. It is common that things may get worse before they get better. And oftentimes steroids are used to manage the swelling. But while patients are on steroids, there could be some side effects, such as difficulty sleeping, overeating, sweating, or agitation, or mood swings, or paranoia. So these are things to keep in mind. But the goal is usually after surgery, we start tapering patients down on the steroids. But steroids are needed in those first few days to weeks to prevent the rebound brain swelling. And then here are just some common postoperative symptoms that are common among a lot of brain tumor patients. And more specific symptoms related to brain tumor surgery really depends on the location of the tumor. So for instance, these are just different locations where brain tumors, primary brain tumors occur and the percentages. So the most frequent location for a brain tumor is actually in the frontal lobe. And the frontal lobe is an area that controls motor movements. So the motor cortex is actually right about here, right at the back of the frontal lobe. And then also controls speech. And there's an area right here in the what we call the inferior frontal lobe called Broca's area that controls expressive language. So patients with tumors in this area, they oftentimes know what they want to say, but they just can't get the word out. So it's the expression of speech that's affected. And then there could be some emotional, behavioral, personality areas in the primary, the frontal lobe anteriorly or in front. One interesting area of the brain is actually right here on the top here in front of the motor cortex, and that's called the supplementary motor area. And this is an area that I've taken out hundreds of times. And oftentimes when this area is taken out, patients do have temporary paralysis or temporary speech loss for anywhere from a few hours to a few weeks. But if the primary motor cortex and fibers are preserved, or the primary speech areas, this function almost always comes back. But it can be scary because after surgery, it could be very profound. But that's just something to keep in mind, that, you know, there are certain areas of the brain that control these voluntary speech and motor functions. And they are resectable, meaning we can take them out, but they do cause these temporary deficits. And it's oftentimes these tumors in the frontal lobe that experience these. If you have a tumor in the temporal lobe, the types of symptoms that patients may have are problems with auditory processing, because hearing processing is in the temporal lobe. And then on the left side, there are also functions related to memory and speech comprehension. So there's an area back here called Wernicke's area, which is the area for comprehensive language. And if you have a tumor in this area, you can speak, you can express language, but the comprehension is affected. So those are all things that we map out before surgery using the functional MRI scanning. And then the reason I mentioned left versus right is because the brain does have dominance. So people who are right-handed tend to have the dominant memory and speech areas on the left side of the brain. So left tumors are more complicated oftentimes than right-sided tumors, because they do involve memory and speech areas. In the parietal lobe, there are also some language comprehension areas, because the parietal lobe is part of Wernicke's area here. But interestingly, the parietal lobe also involves, tumors in the parietal lobe can affect things like mathematical calculations and reading. So those are things that may be affected if you have a parietal lobe tumor. And then the parietal lobe, right in this area here, right behind the frontal lobe, this is the primary sensory cortex. So tumors that affect this area can cause difficulty with sensation, either sensory perception or the physical location of body parts, or the perception of position sense. And then the occipital lobe, which is back here, fewer tumors located in this area, meaning less common. But if you do have a tumor in this area, the initial symptoms are usually visual. It's usually loss of the peripheral vision on the opposite side of the tumor, or things like visual hallucinations, or changes in color perception. So those are just things to keep in mind in terms of symptoms related to the location of the tumor. And then some less common areas are, for instance, the cerebellum, which is down here. So the majority of primary brain tumors occur in the cerebrum, which is up here, but the cerebellum also can have brain tumors that occur in this area. And those are related. If you have a tumor in the cerebellum, sometimes the initial symptoms are difficulties walking, but with difficulties with balance, or gait, or even blinking. or coordination of blinking. And then the brainstem is right here, and there are tumors that occur in the brainstem. And this is an area where oftentimes we don't do surgery because this area connects the cerebral cortex to the spinal cord. And, you know, it really functions to control the ability to walk, speak, swallow, and breathe. So oftentimes we're not able to do very aggressive surgeries when tumors are located in the brainstem. And then the ventricle, sometimes tumors occur in the ventricle. These are kind of fluid spaces in the brain. And the common symptoms related to this is when there's blockage of fluid in the brain. And for some brain tumor patients, you may have had placement of a shunt to drain the fluid because the tumor itself is blocking these fluid spaces. So those are the different locations for brain tumors. And as I mentioned, different symptoms can arise depending on what the location is of the tumor. So those are things to keep in mind. And then the types of tumors can also lead to different symptomatology. And I'm just going to mention the three main types of tumors, but there are many, many others. So the gliomas are one of the main, primary brain tumors, and those are graded 1, 2, 3, 4, and they can be low grade, anaplastic, or glioblastoma. So a grade 2 glioma is called a low grade glioma. A grade 3 glioma is called anaplastic. And then when you hear the term glioblastoma, that is synonymous with a grade 4 glioma. So these are the grades, and then there are two main types, although there's many others. The two main types, and the main cell types are astrocytoma or oligodendroglioma. And the pathology is important, as I'll get to in subsequent slides. The pathology is important to dictate what the next treatments are after surgery. And then meningiomas are another common type of primary brain tumors. They're actually the highest percentage of all primary brain tumors. There are actually more patients with meningiomas than there are with gliomas. But the majority of meningiomas are benign. So if you look at this graph, the majority of malignant tumors are gliomas. And so if you take all the malignant tumors that are diagnosed, the majority of them are gliomas, and 1% of them are meningiomas. So even though meningiomas are very common, the majority of these are benign and not malignant. So the majority are grade 1. But there are, grade 2 meningiomas, which are called atypical, and the malignant meningiomas are grade 3. And then metastatic brain tumors are tumors from cancers in other parts of the body that travel to the brain. And 30% of people with cancers in other parts of the body will develop brain metastases or mets to the brain. So that's also something that we screen for in patients with these types of cancers. Not all cancers go to the brain, but the primary ones are lung, melanoma, breast, kidney, and colon cancer. Other cancers don't typically travel to the brain as much. This is, some information about histological typing. I kind of already went over this, the cell type, astrocytoma versus oligodendroglioma. Meningiomas also have different types, and the metastatic tumors have different types too. So the pathologist will look at the tumor that's taken out and grade it or describe it based on histologic type and or the pathologic grading. And also there are now a battery of molecular tests that are typically done on gliomas, for example, such as IDH1 mutation, MGMT methylation, 1p19q co-deletion, ATRX mutation. If you have a 1p19q co-deletion and a TERT promoter mutation, most likely this is now it's diagnostic of a oligodendroglioma. If you have an ATRX mutation, then most likely you have an astrocytoma. So these mutational tests also help confirm the diagnosis and future directions. And then there's some grade 1 tumors that have a BRAF mutation. And now there are agents that block BRAF mutations that can be used for treatment of some of these tumors. And then, keep in mind, some clinical trials do require collection and processing of tumor tissue at the time of surgery. So it's important when you, even before going into surgery, that you discuss these things with your surgeon, because you want to have as many options available as possible after surgery. So things that the better prepared you and your surgeon are going into surgery, the better the outcomes. And then these are just the NCCN guidelines for what to do after surgery and after pathology. So we talked about, how to maximize, surgical outcomes. We talked about, the pathology and the different types of pathologies of brain tumors and why they're important. And then the next steps are really future treatments and adjuvant treatments. And so depending on the pathology, so for instance, low-grade gliomas, if you have one of these types, and these tend, polycytic astrocytoma is a grade 1 glioma, or something called a SEGA, subependymal giant cell glioma. These are more rare tumors, but they do have, for instance, if you happen to have one of these tumors, one of the recommendations is to consider a BRAF and MEK inhibitor, because these agents do tend to show some efficacy for these types of tumors if the tumor has those mutations. And then, for instance, if you have a SEGA, the mTOR inhibitors may be an option for these tumors. And then, but otherwise follow every, MRI scans for 3 to 6 months initially, and then 3 to 5 years, and then annually thereafter. For the other types of low-grade tumors, for instance, the astrocytomas or the oligodendrogliomas, and these are the molecular markers that define them. If you're at low risk, then oftentimes we just observe. We don't do any adjuvant treatment. We just get MRI scans every 3 months for the first 3 to 6 months for the first 5 years, and then every 6 to 12 months thereafter. And I have dozens and dozens of patients that I follow just once a year with these tumors, and we get a scan once a year, and that's it. We just keep following them. If it's a higher risk, then there are different chemotherapy options. PCV oftentimes would be used for oligodendrogliomas, whereas temozolomide is the treatment of choice for astrocytomas. And then, this is just more, I'm not going to go through the details of all these graphs, but these are available at the NCCN network sites in terms of what the guidelines are for these tumors. Anaplastic gliomas, which is the grade 3 gliomas. So with anaplastic tumors, even if we get all the tumor out that we can see, what we call a gross total resection, we do go on to subsequent treatment. And the subsequent treatments are either considering clinical trials, standard radiation with PCV chemotherapy, and that's for an oligodendroglioma, or standard radiation with temozolomide. If it's an astrocytoma, the recommendation would be radiation and followed by temozolomide. And then anaplastic gliomas, if you have a poor performance status, meaning bedridden or not able to carry on with activities of daily living, then most patients do one of these and not necessarily a combination of everything. Same for glioblastoma, and although there is some segregation depending on whether you have this MGMT promoter methylation. The methylation does suggest a better response to chemotherapy. So patients tend to be more aggressively treated with chemotherapy if they're methylated versus unmethylated, although the standard of care is still pretty much the same for both groups, which is temozolomide and radiation. Gonna go to just the last couple slides on meningiomas. So meningiomas, as I said, the majority are benign. So usually the treatment, even sometimes we don't even do surgery if the tumor is small and not causing any symptoms. So if the tumor is small and asymptomatic, surgery is oftentimes not even done for meningiomas. We just watch with serial MRI scans. However, if the tumors are large or causing symptoms, then we do go on to surgical resection. And then depending on the grade, as I mentioned, there's grades 1, 2, and 3. The majority of meningiomas are grade 1, and usually surgery is it. We don't do any subsequent observation. We don't do any subsequent radiation. We just do observation, and only radiation if patients are symptomatic or if there's a large tumor left behind. But usually, for grade 1 tumors, we don't do anything beyond the surgery. For grade 3, because those are malignant, we do recommend radiation therapy after surgery. Grade 2 tumors, grade 2 meningiomas are in the gray zone. Sometimes we consider radiation and sometimes we do not. And some of that is dictated on the extent of resection, how much tumor is left behind, but also on the age of the patient and then the goals of the treatment. And then follow-up for meningiomas, usually we just get scans every 3, 6, and 12 months, and then probably every 6 to 12 months for the first 5 years, and then every 1 to 3 years after that. And then we follow patients indefinitely for scans every 3 years or so. And brain metastases, a lot of this is dictated by the systemic disease. So it's really dependent on control of for instance, the breast cancer or the lung cancer systemically. But so if there's a lot of systemic disease with poor treatment options, then we usually do not consider surgery, but may opt for radiation, either whole brain or now more commonly stereotactic radiosurgery. If they're stable, if there's stable systemic disease and not a lot of brain metastases, the preferred option now is actually stereotactic radiosurgery. So with that, I just wanted to say thank you for your time. And these are some resources that are available through the ABTA that you can go to for further information about brain tumors, about brain surgery, and what to do after brain surgery. Thank you very much.
Thank you so much, Dr. Liau, for your wonderful presentation. We do have time for questions. As a reminder, if you have a question that you'd like to ask, please type and submit it using the question and answer box on the bottom of your screen, and we'll answer questions as time allows. So one of the first questions that we have here, towards the beginning of the presentation, you had mentioned the importance of preparing for surgery and what's to come after. Do you have, can you share some questions or considerations that patients and families should keep in mind when consulting with their neurosurgeons, so that they're better prepared both for the surgery and then what might happen afterwards, the recovery process and outcomes?
Yeah, well, I mean, I think as I mentioned, it's good to have a two-way conversation, with the surgeon, and a lot of, what the outcomes are after surgery does depend on the location of the tumor, the size of the tumor, and the type of the tumor. So those are important things to consider. The medical, comorbidities, the more optimized that is, the better. In terms of control, for that. And I think, most surgeons that do brain surgery, it will guide you through this, the process. And if there are questions that, that you may feel like you forgot to answer or can't answer, I think that's where, places like the ABTA will, are helpful, because you can go to those resources to see, to see, what you may have missed.
Thank you so much for that wonderful advice. Another question we have here is kind of along the same lines in providing advice for patients and families when they're trying to find the right treatment center or the right neurosurgeon to go through with for their surgery. What are some considerations that they should keep in mind? What should they look for when picking an appropriate neurosurgeon or treatment center for themselves?
Yeah, good question. Well, I think when picking an appropriate surgeon, you want someone who's done a lot of these. So probably it's best to pick a surgeon who focuses on brain tumors. Not all neurosurgeons focus on brain tumors. There are some neurosurgeons that do spine surgery, some that do aneurysms and vascular surgeries. Here at UCLA we have 20 neurosurgeons, and some of us focus on each of these subspecialties. So I think that's important. Find someone who focuses on the disease that you have, for instance, brain tumors, and someone that's done a lot of these. And then also, equally as important, or probably even more so, is the center and the team. Because as I mentioned, it's not just the surgery, it's really the preparation going into the surgery as well as what happens after surgery. And a lot of brain tumor centers have tumor boards, and many of our patients are discussed at tumor board even before surgery, so that we come up with a plan as to what to do before surgery, during surgery, and even after surgery. So I think things to look for are the focus and expertise of the surgeon, as well as the ability of and presence of the entire team, namely radiologists, radiation oncologists, and neuro-oncologists.
Thank you so much. We have one of our attendees here asking if you could please share the slide that had the resources again. We'll just keep that up. Some of our attendees want to jot down some of those links and resources that you shared. And just as a reminder for attendees as well, those resources will be shared with you in the follow-up email in a resource handout, so you can download any of these links there. Another question we have, you had mentioned in your presentation the importance of having tissue frozen for future analysis. Can you share why you are recommending that? Is that for future treatment options, or what is the purpose of having their tissue frozen for further analysis?
Yeah, so there are some clinical trials that do require frozen tissue. For instance, for next generation sequencing tests, or kind of determination of certain biomarkers. Like if you have a certain mutation, you may be eligible for certain clinical trials, but you need the tissue to be able to assess whether or not the tumor has that mutation. And I must say that the field has been evolving in terms of what needs to be preserved or not preserved for trials. And I think it's best to kind of have all options available, because how we kind of analyze and preserve tissues today, may be different than what it is 5 years from now, and it's certainly different than what it was 20 years ago. So I think it would be good to kind of research what options are potentially available, and have as many options open as possible. I mean, there are some clinical trials, as many of you know, that are, for instance, that use the actual tumor tissue to make vaccines or other treatments. And without the tumor tissue taken out and processed at the time of surgery, then sometimes patients will not be eligible for that trial. But there are different trials that occur at throughout the course of time and at different centers. So I think just exploring as many options as possible is probably the best recommendation.
Thank you. Now, in your presentation, you had also talked about some of the short-term or long-term side effects that patients may experience after surgery. Is it also common for patients to experience late effects from their surgery? They might have reacted well post-surgery and in the recent upcoming weeks and months, but now it's been some time since that surgery, and now they're starting to experience side effects. Is that common? If so, what are some indications that might help patients or doctors to better understand if a patient is at risk of late effects from their surgery?
Yeah, no, that's a good question. The patients do sometimes experience late effects after surgery. It's very hard to tease out whether that is at all related to the surgery, or to the chemotherapy, or to the radiation, or to the tumor itself. So that's kind of the difficulty. It's hard to say that this patient will have late effects after surgery and this patient won't, because when we actually looked at the data, there's so many factors that could play into the, kind of long-term side effects of any of these treatments, and they probably, are combined sometimes in terms of their how they're attributing to the long-term effects. I mean, there's long been thought of, like for instance, we often do not irradiate younger patients, and we've moved away from whole brain radiation that used to be done, in the past to more focused radiation, because there are long-term side effects to radiating the whole brain, cognitive side effects. So in answer to your question, I think the goal of surgery is really to take out as much tumor as possible to preserve the normal functioning brain. How patients, I guess, recover in the long term, I think sometimes those long-term side effects are not necessarily related to the surgery, but it's related to the subsequent treatments that occur after the surgery that can play into, what happens later.
Thank you so much. That's great insight. Thank you for sharing that. We will take just one last question. So this question is asking you had shared that post-operation, some patients may be prescribed anti-seizure medications for management of symptoms and just to help their recovery. Can you share, I know this can differ from patient to patient, but on average, how long are patients required to stay on medications like that after their surgery?
Yeah, good question. So that's still not, definitively defined in the field, and that's probably why people get different recommendations. So usually, in terms of staying on seizure medications after surgery, I think the main factor to take into account is whether or not the patients had seizures before surgery. So if you had seizures and were on, are on seizure medications before surgery, then usually the risk of seizures after surgery, still can persist, and they usually keep patients on medications after surgery for at least 3 months, if not a year, as long as, and then taper off if they're seizure free after that. Unlike epilepsy patients, patients who have seizures due to brain tumors, the seizures are caused by the tumor. So my feeling is if you take out the tumor, the risk of seizures actually go down compared to what they were before surgery. So oftentimes patients may have seizures before surgery, but they actually go down after surgery. So if that's the case, we can taper down, more quickly. But I think it really depends on, whether or not patients had seizures before surgery. If they do, then usually, like I said, 3 months to a year is how long we keep patients on after. If they did not have seizures before surgery, that could be, quicker, anywhere from a few weeks to to a month. But again, I always do keep patients on seizure medications at least for the first week or two after surgery, because the risk of seizures actually goes up right after surgery. But then over time, over a month or so, the risk actually goes down, and the risk is lower than it was before surgery. So I'd say roughly a month or so is how long I would keep patients on. But as I mentioned, there's no consensus in the field about that.
Thank you for sharing that. And that is all the time that we have for today. Thank you all for joining us. And again, Dr. Liau, thank you so much for your wonderful presentation and for answering these great questions from our attendees.
Thank you.
Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.